Hello guys, today we will talk about dislocations of the forearm, and it's less interesting topic than, for example, dislocations of the shoulder, head and shoulders, dislocations of the shoulder. Yeah, but you need to know about it because it's not be often in your practice, but sometimes you will work with these patients. Okay, when we talk about forearm dislocations, account for 18, maybe 27% of all dislocations. There is dislocations of both forearm bones, posteriorly, anteriorly, outward, inward, and divergent dislocation. Dislocation of the radius, anteriorly, posteriorly, outward, and dislocation of the ulna. When we talk about dislocations of both forearm bones posteriorly, we need to talk that mechanism of injury, like in all dislocation, is indirect, but there we talk about falling on an outstretched arm with overextension in the elbow joint. Yeah, and when we talk about it, our arm will go forward, yeah, and with pushing on the floor it will repush, yeah, and there when we talk about humerus go forward, and elbow don't stop the humerus, and we have any problem with forearm dislocation. When we talk about clinical pictures, they are concerned about pain and dysfunction in the elbow joint, which occurred after the injury. The joint is swollen, deformed. On the back surface, at some distance from the shoulder, the ulnar process will stand under the skin. The triangle and the gutter line are broken. I want to know that you remember what is a gutter line, because it really can help you when we talk about dislocations of the forearm. The forearm is shortened. There are no active and passive movements in the elbow joint. Trying to do them cause acute pain. A positive symptom of spring resistance is noted. On radiographs, we of course need do radiographs in two position, in two projections, and separation of the articulation surfaces of the shoulder and forearm is revealed. Yeah, there you see normal physiology position, and there you see X-ray of dislocations. Okay, please don't forget, you need to clarify the diagnosis, and you need to check motor function and skin sensitivity in the area of the innervation of the ulnar, radial, and medial nerves. Yeah, and there you see about this innervation. Yeah, and if you if you understand that some kind of innervation is not normal, yeah, is damage, you need to think about damage of these nerves. Okay, treatment. The reduction of the forearm is carried out under general or local anesthesia. The arm is withdrawn and slightly unbent at the elbow joint. The surgeon covers the shoulder in the lower third with two hands so the thumbs rest on the superior ulnar process. You can see this on the picture. The assistant holds hand. Traction is performed along the axis of the limb, and the surgeon moves the ulnar process and the head of the radius anteriorly with his thumbs, while pulling the shoulder posteriorly and using it as a fulcrum. If the forearm is set, three passive movements appear. The limb is fixed with a posterior plaster, splint from the upper third of the shoulder to the heads of the metacarpal bones with mandatory radiography. The period of immobilization is 5 or 10 days. And there you see immobilization, how we need to do a cast immobilization. And there you see some types of reduction. For example, there we talk about forward dislocation, and we do this type of reduction where surgeon pushed the arm, and there you see a back dislocation. And all what we need, we can do the same situation, same reduction, or we can do this reduction. And we can do this reduction. There you need to understand that you need to fixate this part of arm, and you need to do some re-pulling of this part of arm, and then just pushed or pull this part of arm for arm, palm, and another. And don't forget to immobilize it, because it will be very hard to reduction the dislocation what happened in second time. Then rehabilitation treatment is prescribed. Physical therapy, physiotherapy. In the early stages of treatment, elbow joint, massage, mechanotherapy, forced passive movements should not be prescribed, since they are gross irritants and enhancers of ossification of the periarticular tissues. Recovery of working capacity occurs after 6-8 weeks. Okay, and now we need to talk about dislocations of the metacarpal bones and phalanx of the fingers. But there you need to understand that all of these dislocations are rarely. It is not very hard for doctors to understand and to reduce it. Reduce or to reduce it. And there we will talk about the metacarpal phalanx of first joint or first finger. Dislocation of the first finger of the thumb. Very rarely there is a dislocation of the thumb anteriorly. The typical form should be considered a dislocation posteriorly and upward. And about etiology, about mechanism, the cause of the occurrence, the cause, the reason of the occurrence are injuries of an indirect mechanism, physical impact on the finger from the palm, side leading to over extension, and posterior displacement. Patients are concerned about pain and dysfunction of the metacarpophalangeal joint of the first finger of the hand. The brush has a characteristic appearance. The terminal phalanx of the first finger is bent. The main one is almost at right angles to the metacarpal bone. The head of the latter will stand under the skin of the palm surface. Movements in the metacarpophalangeal joint are impossible. A positive symptom of spring resistance. To confirm the diagnosis, it is necessary to do an X-ray. And what about treatment? We need to reduction just with general or local anesthesia. A loop of twist bandage is put on the terminal phalanx there. Of the first finger, for the ends of which the surgeon performs traction along the length of the finger and increases the extension, like this one, of the main phalanx to an acute angle. With the thumb of the second hand, the doctor shifts the proximal part of the main phalanx so that it slides along the metacarpal bone, and as soon as the edge of the articular surfaces contact, the finger is bent. It is necessary to control restoration of movements in the joint, because you need to understand that we have some complication. About these complications we will talk in next slide. A plaster splint is applied from the upper third of the forearm to the end of the first finger. The remaining fingers are free. Starting from the heads of the metacarpal bones, perform a control radiography. The period of immobilization is 3 weeks. Okay, now we will talk about restorative treatment. Then rehabilitation treatment is prescribed. Physical therapy, also carried warm baths. Recovery of working capacity occurs after 4 or 6 weeks. And now try to understand something about complications of reduction. Yeah, you understand that we have this joint and there we have many options. In some cases, the reduction of the first finger in a closed way is impossible. There is an interposition of the flexor tendon, interposition, and we can do a reduction. Sesamoid points of fragments of the capsule between the articulation surfaces. Yeah, for example, some bones go. You know that we have sesamoid bones. That it is non-regular. Yeah, new bones. 1 in 10 people. It will be normal, but it's not normal. Yes, and these bones, for example, if it was there before, it go to joint. And of course, when we talk about capsule, if it will broke, that some part of capsule can go to joint. If several correctly performed attempts did not lead to reduction, surgical treatment is indicated. Okay, and now that's all what I want to tell you about forearm, yeah, and about upper limb. In next 2 topics we will talk about lower limb. Be healthy and don't worry, remember that all will be better than today. Thank you very much. Have a nice day.